Hello everyone and welcome to the channel. Today I'm going to give you a full scientific breakdown of oxymetholone, exactly how it works at the receptor level, what the human data actually says about benefits and risks, what to expect from a cycle, and crucially, how to manage the side effects that make it one of the most aggressive tools in the book. This is for education, not a recommendation. You are responsible for what you put in your body. Let's start with a definition. Oxymetholone, brand name Anadrol or Anapol, is a synthetic anabolic androgenic steroid derived from testosterone. Specifically, it's a 17 alpha alkylated derivative of 4,5 alpha dihydrotestosterone with a hydroxymethylene group at position 2. I'll explain why that 17 alpha alkyl modification matters shortly. The compound was developed by Syntex in 1960 and approved by the US FDA for the treatment of anemias caused by deficient red cell production. It also indicated for osteoporosis, HIV, wasting, and to stimulate muscle growth in undernourished or underdeveloped patients. What matters for our purposes is that oxymetholone is one of the most potent oral anabolic agent ever developed in terms of raw mass and strength gain per milligram. To understand what makes oxymetholone so powerful, we need to go down to the androgen receptor. All anabolic androgenic steroids exert their effect primarily by binding to the androgen receptor, a nuclear receptor found in high concentration in skeletal muscle, bone, adipose tissue, and central nervous system. When testosterone, or a synthetic analog, binds to this receptor, the receptor ligand complex translocates to the cell nucleus and acts as a transcription factor, increasing the expression of specific genes involved in protein synthesis and muscle hypertrophy. Oxymetholone does exactly this, but with a unusually high potency. Once bound to the androgen receptor, it triggers a cascade that increases nitrogen retention in muscle tissue, meaning the body stays in a positive nitrogen balance, the biochemical requirement for muscle growth. It also stimulates erythropoiesis, the production of red blood cells, by enhancing erythropoietin secretion and directly stimulating bone marrow. Here is where the 17 alpha alkyl group becomes important. Normally, testosterone is rapidly broken down by first-pass hepatic metabolism when taken orally. The liver destroys it before it reaches the bloodstream. The 17 alpha alkyl modification protects the molecule from this oxidative breakdown, allowing oral bioavailability of approximately 95%. The trade off is that this modification also makes the molecule resistant to hepatic metabolism, which is why it imposes significant liver stress. The elimination half-life is reported at 8 to 9 hours. But there is more. Research shows that oxymetholone upregulates insulin-like growth factor 1 and 2 receptor mRNA in muscle tissue. A 2013 randomized controlled trial in hemodialysis patients demonstrated significantly greater increases in muscle mRNA levels for myosin heavy chain type 2X, IGF-I and IGF-II receptors in oxymetholone group compared to placebo. This means oxymetholone not only increases protein synthesis through androgen receptor activation, but also synthesizes muscle to growth factor signaling, a dual mechanism that partly explain its dramatic effects on lean mass. Let's look at the human data. The landmark study on oxymetholone and body composition was published in the American Journal of Physiology in 2003. Researchers randomized 31 men aged 65 to 80 to receive placebo, 50 mg per day, or 100 mg per day of oxymetholone for 12 weeks. Here is what happened. Total lean body mass increased by 0 plus minus 600 grams in the placebo group, 3.3 plus minus 1.2 kilogram in the 50 milligram group, and 4.2 plus minus 2.4 kilogram in the 100 milligram group. Both active treatment results were statistically significant, with p-values less than thousands. Trunk fat decreased by 0.2 plus minus 0.4 kilogram in placebo, 1.7 plus minus 1 kilogram in 50 milligram group, and 2.2 plus minus 0.9 kilogram for 100 milligram oxymetholone. Strength followed a similar trajectory. One repetition maximum for biaxial chest press increased by 8.2 plus minus 9.2% in the 50 milligram group and 13.9 plus minus 8.1% in 100 milligram group, compared to a decreased 0.8 plus minus 4.3% in placebo, a statistically significant difference with p less than 300ths. For lat pull down, the changes were 0.6 minus 0.6 plus minus 8.3% for placebo, 8.8 plus minus 15.1% for 50 milligram, and 18.4 plus minus 21% for 100 milligram group. In a separate 24-week trial of hemodialysis patient, oxymetholone produced significantly greater increases in fat-free mass, hand grip strength, and type 1 muscle fiber cross-sectional area compared to placebo. This is not just water weight. These are structural changes in muscle tissue at the fiber level. Now, we need to talk about the risk side of the equation, because oxymethalone's side effect profile is serious. Hepatotoxicity is primary concern. Oxymetholone is a 17-alpha alkylated compound, and this structural feature is directly responsible for its liver toxicity. In the same 2003 study I just cited, alanine aminotransferase, a key liver enzyme, increased by 72 plus minus 67 units per liter in the 100 milligram group, which was highly significant with p less than thousands. The literature reports cholestatic jaundice as the most important hepatic side effect, with the less common but more severe events including pliosis hepatis, blood-filled cavities in the liver, and hepatic tumor formation. Cardiovascular risk also rises. The same trial showed HDL cholesterol, the protective lipoprotein, dropped by 19 plus minus 9 milligram per deciliter in the 50 milligram group, and 23 plus minus 18 milligram per deciliter in the 100 milligram group, with p-values of 400ths and 8,000ths. A depressed HDL level is an independent risk factor for atherosclerotic cardiovascular disease. Androgenic side effects include acne, hirsutism, scalp loss, clitoral or phallic enlargement, vocal changes, gynecomastia, amenorrhea in women, and changes in libido and sexual potency. Notably, oxymetholone doesn't aromatize to estrogen through the aromatase enzyme. Yet gynecomastia and water retention still occur, likely through direct estrogen receptor binding or progestogenic activity, a mechanism that complicates management. Suppression of hypothalamic pituitary gonadal axis is also pronounced. Oxymetholone suppresses endogenous testosterone production rapidly and significantly, which is why post-cycle therapy is mandatory and non-negotiable. Oxymetholone is a single chemical entity, not a class. There are no molecular variants with different half-lives in the way we have in testosterone. For example, testosterone enanthate, testosterone propionate, testosterone undecanoate. The active molecule is always the same. What differs is the brand names under which it has been marketed. For example, Anadrol, Anapolone, Adroid, Podroid, Planstril, uh, protanabol, nastanon, sinasterone. These are all chemically identical. Pharmacokinetically, oxymetholone has oral bioavailability of approximately 95%, undergoes hepatic metabolism, has an elimination half-life of 8 to 9 hours, and is excreted 95% via the urinary route. This relatively short half-life means that if you want to maintain a stable blood levels, the daily dose is typically split into two administrations approximately 12 hours apart, though many users take the full dose pre-workout to capitalize on acute strength enhancement. It is worth noting that because the half-life is relatively short and the hepatotoxicity is acute, oxymetholone is almost always used as an oral kickstart to a longer injectable site rather than as a standalone agent for extended period. Given the clinical data, expectations in a resistance training context can be estimated with reasonable accuracy. Over a 4 to 6 week cycle at 50 to 100 mg per day, users typically report lean mass gain in the range of 4 to 7 kilograms, accompanied by significant increases in maximal strength, often 10 to 20% on compound lifts, and a pronounced fullness in the muscle due to increased glycogen retention and water uptake in the sarcoplasm. The onset is rapid. Most users report noticeable strength increases within the first 7 to 10 days of cycle. Appetite stimulation is also commonly reported, which can be an advantage in a caloric surplus context, but also lead to unwanted fat gain if dietary discipline is lacking. It is crucial to understand that a portion of the rapid weight gain is intracellular water retention driven by the estrogenic or progestogenic activity of the compound, not contractile tissue. Post cycle, a percentage of this water will be excreted, and the net lean tissue retention depends on the quality of post cycle therapy and continued training and nutrition. Let's go to the dosages and cycle lengths. In performance context generally ranges from 250 to 100 mg per day. For a first-time user, 50 mg per day is the most commonly cited starting point. The clinical trial data shows a clear dose-response relationship between 50 mg and 100 mg, but also a parallel increases in liver enzyme elevation. Cycle length is limited by hepatotoxicity. the consensus is that oxymetholone shouldn't be used for more than 6 to 8 weeks continuously, and 4 to 6 weeks is more typical in bodybuilding practices. Some advanced users push to 8 weeks, but this increases the risk of clinically significant liver enzyme elevation. Oxymetholone is rarely run alone. It's most commonly used as kickstart to a testosterone base, where it provides a rapid strength and weight gain, while a longer stay injectable compound reach steady state concentration. A common structure is oxymetholone 50 mg per day for week 1 to 4 alongside testosterone enanthate at 300 to 500 mg per week for week 1, for example, to 12 or 8 week, depends on your cycle lengths. On-cycle therapy for oxymetholone is primarily directed at liver protection and cardiovascular risk mitigation. For hepatic support, the evidence-based supplements are N-acetylcysteine or NAC and tauroursodeoxycholic acid or TUDCA. NAC is a precursor to glutathione, the body's master antioxidant, and support both phases of liver detoxification. TUDCA is a bile acid that has shown to reduce endoplasmic reticulum stress and protect hepatocytes from apoptosis. Milk thistle, containing silymarin, is also widely used for its hepatoprotective properties, although the evidence base for its efficacy is weaker than NAC and TUDCA. For cardiovascular support, given the significant HDL suppression, supplementation with omega-3 fatty acids at 2 to 4 grams per day is recommended, along with coenzyme Q10 and regular cardiovascular exercise. Blood pressure must be monitored frequently, as oxymetholone can cause sodium and water retention that may leading to hypertension. On-cycle blood work is non-negotiable. Liver enzymes, lipid profile, and complete blood count should be checked before the cycle, at the midpoint, and within 2 weeks after cessation. Post-cycle therapy is mandatory because oxymetholone suppresses the hypothalamic pituitary testicular axis (HPTA). When the exogenous androgen is removed, the body is left on a hypogonadal state until endogenous production resumes. The goal of PCT is to restart the pulsatile secretion of gonadotropin-releasing hormone from the hypothalamus, which stimulates the pituitary to release luteinizing hormone (LH) and follicle-stimulating hormone (FSH), which in turn signal the Leydig cell in the testes to produce testosterone. The standard PCT protocol involves selective estrogen receptor modulators, or SERMs, clomiphene citrate, commonly known as Clomid, and the first-line agent because it blocks estrogen feedback to the hypothalamus, increasing gonadotropin release. The second one is tamoxifen or Novadex. Is also used particularly for its additional action of blocking estrogen receptors in breast tissue, which helps manage gynecomastia risk. A typical PCT for an oxymetholone inclusive cycle would begin approximately 2 weeks after the last injection of testosterone or immediately after the last oxymetholone dose if it is used alone. Clomid is dosed at 50 mg per day for 4 weeks, often with a front loaded of 100 mg per day for the first 3 to 5 days. Novadex may be added at 20 mg per day. Human chronic gonadotropin, or HCG, sometimes used during the cycle itself to maintain testicular function rather than waiting for recovery afterward. Liver support supplements should be continued throughout PCT to give the organ time to recover fully. So, who is oxymetholone suitable for? This is the most important question of all. Oxymetholone is not suitable for beginners. It's not suitable for anyone who is not willing to conduct regular blood work. It's absolutely not suitable for women due to the high risk of irreversible virilization. The compound is most appropriate for experienced users who have already completed several cycles with milder compounds and who understand their individual response to androgen receptor agonists. It's suited to those in a bulking phase where rapid mass and strength acquisition is the primary goal. It's also used in strength sport, powerlifting, strongman, where weight class consideration are less of a constraint and absolute force production is the metric that matters. Because of its pronounced effect on red blood cell production, oxymetholone can be particularly effective for athletes who have low hematocrit at baseline. However, this same property makes it dangerous for anyone with elevated hematocrit, as it increases the risk of thromboembolic events. Anyone with pre-existing liver impairment, cardiovascular disease, dyslipidemia, or a history of androgen-sensitive cancers should not use this compound. Oxymetholone is a scientifically fascinating drug. The data are clear. It produces rapid and significant increases in lean body mass and strength. And it does so through mechanism we traced from androgen receptor all the way down to muscle fiber cross-sectional area and growth factor genes expression. But the side effect profile is proportional to potency. Liver stress, HDL suppression, hypothalamic pituitary gonadal axis shutdown. These are not minor inconveniences. They are serious physiological disruptions that require active management and medical monitoring. If you take one thing from this video, let it be this: the gap between what a compound can do in controlled research setting and what happens in real world is bridged by preparation, blood work, and honest risk assessment. Train hard, do your research, and make decisions based on data, not dogma. That is the full breakdown. Thank you for listening.